So again, it's my pleasure tonight to welcome everybody for our Key Nerves in the Head and Neck webinar. And I'm very excited that Dr. Yver and Dr. Spector are joining us from the University of Pittsburgh. So it's my pleasure to introduce tonight's moderator. Dr. Yver received her MD from the Perelman School of Medicine at the University of Pennsylvania. She then went on to do head and neck surgery training at the University of Penn and completed a fellowship at Harvard Medical School, where she specialized in facial plastic and reconstructive surgery. She's board certified by the American Board of Odontology and is the director of the UPMC Facial Nerve Center. She's a member of multiple professional organizations. Again, she gave our March webinar on facial nerve, which was outstanding. If anybody didn't see it, we'll resend the link out so you can be sure to see that one as well. But we're very appreciative of Dr. Yver being here tonight as moderator.
Thank you for that very kind introduction. I have the distinct pleasure of introducing Dr. Matt Spector, who is our speaker at today's webinar. So Dr. Spector, he's a professor and he's the division chief of head and neck surgical oncology and microvascular reconstruction at the University of Pittsburgh. We were very fortunate in that he joined our department from the University of Michigan in 2023. So he's been with us almost 2 years. During his tenure at the University of Pittsburgh, he has significantly increased the volume and scope of head and neck reconstructive surgery. He's also served as a co-investigator on, I think, at least 4 different NIH-funded grants. He is a nationally recognized thought leader in all aspects of head and neck surgical oncology and reconstruction, including reconstruction of key cranial nerves affected in head and neck oncologic surgery and head and neck trauma. I'm very pleased to welcome him as today's speaker, and he will be giving us an excellent overview of key nerves in the head and neck. So thank you, Dr. Spector.
Well, again, thank you everybody for joining. This is exciting. I know I hope you guys did catch Dr. Yver's facial nerve talk from about 2 months ago. It was fantastic. As we put these together, Dr. Yver and I thought, well, what nerves do we see the most in the head and neck, and where do we see the most kind of dysfunction, and then how do we create improvements in the function of these nerves? And so I'm going to cover a couple of nerves tonight. Obviously, the facial nerve, if you missed that would be Christina's, and this is going to cover a couple of different nerves. As an introduction, if you think about the importance of the cranial nerves of the head and neck, they are a really complicated and sophisticated group of nerves that control very complex end organs. I mean, think about everything you did today before this webinar, right? You woke up in the morning, you got dressed, you had breakfast or maybe lunch and dinner, you talked to people, you went to your job. I mean, almost everything that you did was a complex set of your cranial nerves with speaking, swallowing, and eating, and it really provides us our identity. And so, as you think about dysfunction, the head and neck cranial nerves are just as important, if not more important, than many of the other nerves or peripheral nerves in your body. And so today, I'm going to cover a couple of different areas. So we're going to talk about the lingual nerve, the inferior alveolar nerve, and the recurrent laryngeal nerve. We'll discuss their function and then their dysfunction and what it means when you have one of these nerves injured. And then again, we'll talk a little bit about how we think about the treatment of these nerve injuries, whether it be primary repair or grafting, and how it improves the quality of life if you have one of these injuries. And so to get right to it, we're going to start with the lingual nerve. And so again, I think a lot of this is people take a lot of this for granted. Like you think about, again, what you did this morning. You had maybe 2 or 3 meals through the day. You enjoyed your cup of coffee. You can't do that without your lingual nerve. So the lingual nerve controls the taste and sensation to the anterior 2/3 of your tongue. So interestingly, in your tongue, the taste and the motor function are 2 different nerves. That doesn't happen all the time or everywhere, but this one is. And so, lingual nerve controls the taste on the front of the tongue, which is probably 90% of your taste buds. The motor nerves are a little bit different. And so, everything that you do, in terms of eating or speaking, that involves the lingual nerve, moving around and having sensation to know where it is in your mouth and then what it's dealing with. Again, so it does just the anterior 2/3 of the tongue. You have paired nerves. And so this gets a little weird, right? Because you can have a single nerve injury, but you can still taste. And so sometimes if one of the nerves or both the nerves are injured, a double nerve injury, especially in all these nerves, is much worse than a single nerve injury. More commonly, a one nerve injury happens, but it's something important to remember. The most common injury to the lingual nerve or the taste nerve is during dental procedures. And so again, we've all been to the dentist office and we get an injection or we have little incisions around the teeth, but the lingual nerve can be injured from a needle itself or from a transection during a procedure. The lingual nerve is actually a branch of what's called the trigeminal nerve or the fifth nerve. So the fifth cranial nerve has 3 divisions, and the lingual nerve is one of those divisions. And so we'll talk about the inferior alveolar nerve as the second part of the talk, but the lingual nerve kind of goes inside of the mandible and goes into your tongue. And if you looked at it from the front, it would be right under the skin. And so any people who have ever bit their tongue really hard and maybe had numbness after or had a cut under their tongue, that can happen from an injury to the underside of the tongue where the lingual nerve is very superficial, just right under the skin. Again, the lingual nerve comes down and has a lot of branches. And so some people actually, even though it's only half the tongue, you can have actually partial lingual nerve injuries where you have a portion of your tongue that could be injured. And this can present as a funny taste, or it can present as an area of numbness on your tongue. This is the most common way it's injured. So this is looking straight through the mouth. And so these are the bottom teeth right here. This is what's called the retromolar trigone, or the bone of the jaw going back up. And the lingual nerve runs out of the skull base and then comes across the jaw and into the tongue. So if you've ever had an injection or an incision back here to work on a third molar or to have like a numbing shot in here, that's where the lingual nerve most commonly gets injured, is it right in the back as it comes into the tongue. It can be injured up front in the frontal part of the tongue, but that's usually like a trauma. So if you bit your tongue accidentally really hard, that's another way this could happen. Also, when cancers of the tongue and floor mouth, which I'll show you a little bit later, if you have any tumors there, people present with a lot of pain, and you can have a lingual nerve injury from that. So I know, again, we talked a little bit about this. It sounds silly, but what does it look like when you have a lingual nerve injury? So, you ask patients and they say, well, I can't eat in public. It's hard to go out in public because I don't know. I can't feel that side of my mouth. I can have a problem talking. I don't like to participate in social activities. Overall, they have a poor health perception. So even though it's just, a single small nerve or a numbness or a problem with one side of the tongue, these are very, important to patients. Lingual nerve injuries are actually quite treatable. And so it all depends on the mechanism and what's happening to the lingual nerve. And so this is an algorithm that we think about when we talk about lingual nerve injuries and what can happen. So again, usually we try to figure out the inciting event. Was it after a procedure that they had? Was there an injury that happened? Was there a trauma? Is there any cancer in the mouth? So a good exam of the mouth can be important. We typically get an MRI for something like this. It's pretty rare, but you can have other things that could cause some kind of taste disturbances. So we look at the nerve as it comes out of the brain and then all the way down as it goes into the tongue. Most lingual nerve injuries get better on their own. So the first thing to do is kind of serially watch it and really document the sensory disperception that someone's having. And so we get an MRI, we make sure that's all normal, and then we can serially monitor this. If everything gets better on its own, then we know that it's going to be okay, and then no further intervention. But if you have a persistently poor anesthesia of the tongue, so it's really numb and you can't feel anything and it's not getting better and your MRI is normal and we kind of know there's this traumatic event, we know we can go in there and find the injury. So microneural surgery, and I'll show you a couple of pictures here in a few slides. We can actually go in and look for the nerve and find the area of injury, and then we can either graft that area or fix that area or decompress that area. And so after microneural surgery, most people get some benefit or they feel it starts to get better. If it doesn't work, even after surgery, there are some re-education therapies where we can kind of trick your brain into thinking that it's getting better in that area, kind of like a phantom or a mirror effect. The same thing happens with pain. So Sometimes we're lucky and it's a numb area, which can still be bothersome, but sometimes nerve injuries can have chronic pain. And these are actually a little bit harder to treat. Chronic pain can be from an area of the nerve that's not firing properly along the axon. It can be from a neuroma or a little ball or a scar ball that forms within the nerve. And so again, the same type of thing can happen. So if I see someone with kind of lingual nerve pain, we get the MRI to make sure that things look normal. And then we can do these, again, serial examinations. So there's a concept, I know it's kind of silly, and if you think about this, it's maybe true. We've all been sick, right? You've gotten a cold or a head cold, you've gotten a cough, and somehow it's gotten better. And sometimes you didn't have to do anything at all, just wait it out and it gets better. So a lot of these, it regresses to the mean. So that concept is where it's going to get better with time. We have to let the body heal itself. And if it can heal that neuroma or that pain or scar ball, then that's perfect. And if not, we can try to intervene to see if we can improve it. And so we do something called a diagnostic lingual nerve block. So we actually can inject some lidocaine carefully around the nerve. And then if that relieves the pain, that's a pretty good indication that that's not, number one, the area that the nerve is injured in. And number two, there's something to be said about doing surgery in that area. So if you have relief of your pain with a lingual nerve block, we can go in again, do a microneural surgery. We use magnification to find that area or scar ball along the nerve. We can excise that scar ball, and then we can regraft or reconnect the nerve in that area. If the pain, no pain relief for the lingual nerve block, there are some non-operative therapies. Some people have used some different pharmacologic therapies. So anti-epileptics, antidepressants, and a pain referral can be very helpful. And then again, sometimes we can retrain people's mind to kind of focus on other things, and the pain can get better over time. So the lingual nerve, again, is a bothersome thing. The inferior alveolar nerve, though, is actually a little worse. And so this is another branch of the trigeminal nerve. And so as it comes out, the trigeminal nerve has that first lingual nerve branch. But then this inferior alveolar nerve branch goes to the jaw and lower teeth. And so again, if you can imagine, whenever you get numbed or you have lower molar work, you have an inferior alveolar nerve block. And so you get an injection of numbing medication around this nerve. It can numb the entire bottom jaw. It can numb the lip in the front side there. And so it's really useful when you're getting dental work, but it also can be very bothersome if you have an injury. So this nerve, again, the lip and the chin, it provides all the sensation to this area. Again, it's a paired nerve, so you can have a unilateral injury. You can, again, have a bilateral injury, which is obviously worse, but that's a pretty rare event. And again, the most common time you would get this is a nerve injury related to dental work. So whether you're getting an extraction or a root canal, and again, in some cancers, we do remove this nerve too when it's involved in that area, which leaves with permanent numbness. So here's an example of how that can happen, right? We've all, or most of us have had wisdom teeth. Not everybody has them, but if you have wisdom teeth, they can be in different positions in your jaw. So the wisdom tooth is another name is the third molar or the back molar. Sometimes it's pretty far away from the nerve canal. So here you can see the third molar is pretty far away from the nerve canal in this case. And then in different locations, either one root or both of the roots can be touching in that nerve canal. So a lot of times people will go in, they'll get a nerve block, and then they'll have the tooth pulled. And when you pull the tooth, it can fracture along that nerve and cause trauma to it. And it's actually very hard to figure out, right? Because you're numb. So you don't quite know the nerve injury is there. And you may, be numb for 4 to 6 hours. So it can take days for some of these to really understand that it's not going to come back. What does this look like in a little closer picture? So here's an impacted third molar. So these again, this is looking at the back of the jaw here. These little white spots are little fillings on the teeth. And you can see this molar is pushing right into that tooth. And then here, this kind of faint line here is the nerve canal. So this root here is going right into that nerve canal, and the tooth is being pushed this way. So a lot of times the oral surgery team has a heck of a time getting these out, and you can see where one false move here can go right onto that nerve canal. And then another way is implant placement. So again, As we get older and the teeth have less repair or there's injury to the teeth, you can get implants, right? So you can get a partial or a denture, or you could have a full denture, or you can get implants to hold in the denture. There's a lot of different kind of ways to reconstruct or rebuild the teeth. These are examples of dental implants, and these are placed in the clinic many times by your oral surgeon. But you can see these have to be very carefully placed, and this implant goes right into the nerve canal. So again, you might have a numbing procedure to have an implant placed. The implant placement goes perfectly and everything's great. 4 to 6 hours, you're still numb. 2 days later, you're still numb. But this nerve can just have an implant right there that could be causing a permanent or a semi-permanent numbness. I'll show you one other way this can happen. And so this is a panorex. So what this does is that you've probably seen this of yourself when you go to the dentist office. This gives you a full view of all the teeth in one shot. This tooth you can see has had a root canal. And sometimes when they inject the medicine to the root canal, it can get into the inferior alveolar nerve canal. So on this side, you can see there's material down in the roots, and you can see there's material that got into the inferior alveolar nerve. So again, going in for a routine dental procedure, like a root canal, and you can wake up and wake up numb, and then it can be numb for days, weeks, or months. So what do patients say about numbness, right? And so this is a problem. So the teeth being numb themselves are actually not a problem. It's more of the lip. So think about the number of times when you're kind of eating in public or speaking in public, you don't want to drool. And so you can with no sensation of the lip, you could end up drooling and not even knowing it. And so people get very, very self-aware of their speech. And so they don't want to go out. Their speech deterioration can go down. So if you think about when you're talking, you feel your lips come together, you feel your tongue touch your teeth and the roof of your mouth and your lips. And so people notice that their speech gets worse with this numbness. And so with these limitations of kind of eating and speech, people don't want to participate in social events. They don't like to go out anymore. So again, if this can be a huge problem for patients. And then again, we actually can do testing in the clinic, and this is pretty obvious. People say their lips numb, but this is just an example of how you could actually mark out the actual area of numbness on someone's lip after an injury like this. The good news is there are some treatments for this, and so we're able to do a few things. This is one example that's described in the literature, so we can sometimes know there's only one place for the implant to go. So, when you need implants, this canal will still be in the way, but you can actually open up the bone and move the nerve and then place a special protection around the nerve. So when the implant goes in, it doesn't injure the nerve at all or rub on the nerve. So this is one kind of novel way of kind of preventative, surgery to repair something like this. If the nerve injury has already happened, we can actually go in and repair the nerve. So again, we know the nerve comes out of the lip. Usually it comes out around the same spot, around the first premolar. You can make an incision in the mouth, and this is an example of that. So an incision along the gum, lift up the covering of the bone, and here's the nerve coming out into the lip here. And so usually the nerve is injured in the bone. So the next step is to drill that bone out. So we can actually remove a good amount of this bone here. And then here's some gross pictures, but you can find the area of injury. So what you're seeing here is you're looking directly onto the bone through the mouth. This little green background goes behind the nerve to kind of pull it forward. And then this is the nerve running through the jaw. You can cut this kind of segment out. You can see there's this scar ball that's formed here. And then you can either repair this primarily or use a nerve from another part of the body or what's called an allograft to repair this. And so this can return that sensation to your lower lip, at least partly, and relieve pain if there's a pain point associated to it. The last nerve we're going to talk about tonight is the recurrent laryngeal nerve. And so this one's a little different. And so this is not typically related to through dental or oral areas. The recurrent laryngeal nerve, as kind of figured out by the title, goes to the voice box. And so this is another very common nerve that we see. and it's another nerve that we see that gets injured. And so again, this goes to your vocal cord. So your voice box really has three main functions. Speech is one of the more obvious ones, right? Swallowing is another function of the voice box. So every time you swallow, your vocal cords go together and the lid of the voice box goes down, and then you're able to swallow. And then your voice box also opens to breathe. So every breath that you take, your vocal cords are going to open. And so any type of injury to that can affect swallowing, it can affect speech, and it can affect breathing. These are also paired nerves. And so again, you have one coming from each side to control the left and the right vocal cord. These nerves have a couple of ways of being injured. Every time you have an intubation, they put a breathing tube through your vocal cords and into your windpipe. Sometimes the pressure from the endotracheal tube can cause damage. If you're having or had thyroid surgery, those nerves are right near the thyroid surgery, and I'll show you some pictures of that. And so that's another very common way we see nerve injuries, whether there be a cancer involved in the thyroid gland, or it's what we call an iatrogenic or an accidental injury. And then some people have a viral infection. And so sometimes you wake up and you're just hoarse and you can't swallow, and it could just be a virus that knocks out that nerve. We see that, Christina talked a little bit about that at her webinar, where the facial nerve can be knocked out by a virus, and that we call that Bell's palsy. A nerve that's knocked out or the recurrent laryngeal nerve doesn't have a specific name, but again, a virally associated palsy is also possible. This is pretty rough, right? Again, think about your day that you had today. You woke up, maybe you said goodbye to your kids or your family members. You went to work and you talked to people at work. You had a few meals, so you had to swallow a few times. And so, again, a recurrent laryngeal nerve injury affects really every moment of your life. The anatomy here is pretty cool. I don't know if you've ever seen anything like this, but it's a kind of a cool thing. This is actually the most narrow part of your airway, like your breathing pipe. And so it's actually it's less than it's less than 2 centimeters in most air. It can be less than a centimeter times, but this is the vocal cords. And so again, when the vocal cords close, like in the right diagram, you can talk and they vibrate so you can make different sounds. When you're trying to breathe, right, when you're taking a deep breath in or sniffing, your vocal cords open to help you get a full breath. And then it's a very complicated set of muscles that run this, and all those muscles are really run by the recurrent laryngeal nerve. There's actually 3 nerves that go to the voice box, but the recurrent is by far the most important. So you have 2 superior nerves that come down from the top. And those really control a little bit differently. Those are like the sensation to the top of the voice box and just one muscle. The recurrent runs the rest of the muscles and really all of the breathing muscle. And it controls the only one that opens the voice box, which is actually the most important for breathing. Again, I mentioned this already. Again, the superior laryngeal nerve does sensation. They're both branches of the vagus nerve, which is cranial nerve 10. And so they all branch from the vagus nerve. It's just where they branch from is is the difference. There's sensation branches from the internal branch of the superior laryngeal nerve, and then the external branch controls one muscle, and that muscle controls pitch. So sometimes if you have a superior laryngeal nerve injury, especially in a singer, it can affect your pitch, but really it's kind of an understudied and not a supremely important nerve. The recurrent, though, is very important. And so again, the sensation to the vocal cords, which are kind of the last protector of the airway. So when you really cough hard, that's your glottis or your recurrent laryngeal nerve working overtime. They all run through the chest, which is actually an interesting way of the nerve going there. That's why it's called recurrent. So if you think about most nerves, they run from your brain and then they go out, right? So you have nerves from your brain that go to your arms. You have nerves from your brain to your spinal cord that go to your legs. This nerve actually runs down from your brain, goes down almost into your chest or into your chest, and then comes back up. Very few nerves actually do that. So it's kind of a cool way to see one of these nerves. So interestingly, injuries in the chest, if you have a high chest injury for some reason or a high lung cancer, it can cause, a paralysis of this nerve. This is a reason why thyroid surgery is really at risk for this nerve. So this is a CAT scan. So what a CAT scan really is it shows you the density of the tissues as it passes X-rays through them. So this is the front of the neck up here. This is the back of the neck. This is the spine. So these white are bones here. This black circle in the middle is the breathing pipe. This darker gray area here is your esophagus. And on each side of these are the thyroid gland. So this gray kind of trapezoid shaped thing is the thyroid gland on each side. And the nerve runs right in here where my arrow is. So it's in between the trachea, the esophagus, and the thyroid gland. So you can imagine when working on this area, you got to be very careful to preserve that nerve and trace it up so you're careful of the trachea, the esophagus, and the thyroid. Again, one more picture of that nerve to see how close it is to everything. Again, here's the trachea in the middle here. Here's the esophagus, and that nerve runs right in the middle here. And you can see it goes under the thyroid gland. So every time we take out the thyroid gland, you have to very carefully trace this nerve. And then you can see there's little arterial branches that you have to be careful of, but you have to take down these little arterial branches that can weave in between the nerve. What does this look like intraoperatively? Again, here's a picture of a nerve. Again, you can see the thyroid gland is going to be down here or pulled back. This is the trachea right here. You can see a nerve, kind of this whitish glowing, gleaming structure that goes into here. Out of all the nerves that we've talked about so far, this is probably the biggest effector of a quality of life of somebody. And so obviously all these can have different detriments, but the ability to get, as we talked about, breathe, swallow, and speak really help define who we are and what we do every day. And so, not being able to, for example, to give a webinar like this, or to be able to talk aloud, to be able to talk to your family or friends, or to be able to talk on the phone to loved ones or for business, that's a very difficult thing to do. And then swallowing is very tricky. And so remember, the vocal cords shut every time you swallow. So if you're moving only one vocal cord and the other one doesn't move, you can imagine that things can sneak down there. So you can have aspiration or pneumonia, and those are very difficult to deal with over time. And then lastly, I remember this distinctly. I had a patient, she was in her mid-40s, and she had a tumor of one of her nerves that controlled the voice box. And so when we removed that, which unfortunately had to come out, her biggest complaint was that she couldn't run anymore. And so, trying to run, if you think about when you're running, you're trying to take very deep breaths in. And if your vocal cords don't fully open when you breathe, you get something called dyspnea on exertion, where you get, a hard time breathing when you're running. So that's a very tough thing to deal with, especially if you're an avid runner or an exercise enthusiast. The good news is there are some treatments for this. And so again, as you can imagine, as you're learning from this webinar, the first thing we do is give it time. So whether it's a virus that knocks it out, or if you had an intubation where you wake up hoarse, a lot of these recover on their own. So we give them a lot of time. And so by a lot, I usually mean 3 to 6 months. During that time, though, there are things we can do to help with some of the symptoms. And so there's something called a vocal cord injection that I'll show you some photos on. You can have a vocal cord implant, and then there's nerve grafting, which I'll touch on as well. So what is a vocal cord injection? So the premise of this not working, right, the vocal cord, is that it's not touching the other vocal cord when you're talking. So the one vocal cord's moving fully, the other one's not moving, and you're trying to generate sound out of the voice box. So you can actually take a small needle and put it in the vocal cord from the outside, watch yourself doing it from the inside so you can see the vocal cord, and then you can inject filler. So the fillers that we use are just like fillers you might get in your lips or your creases of the face. You can inject a material that pushes that vocal cord over. So then when you talk, you can have a solid phonation and you're able to speak loudly. This works for speech, obviously, because it closes the vocal cords. It can work for swallowing, right? Because then the vocal cord is easier. It has a closer distance you can have for swallowing. It doesn't so well work for dyspnea on exertion, right? So trying to run, it can actually make it a little worse to put more material in there because you have a smaller kind of breathing pipe. The same thing goes with an implant. So this is a very clever thing. And so what you can do is you can make a small incision on the outside of the neck, and they make these small little silicone implants. And so you can take a little window outside of the thyroid cartilage, and you can put this little implant in there to push the vocal cord over. The injectable materials last for 6 to 9 months. This is a more permanent fix. So if we don't expect a nerve to recover, we can put a small implant in here. It can push the vocal cord over. Again, it can provide a really good voice. You can actually put these implants in awake to test the voice while you're doing it. And then it can also help with swallowing, right? Because it pushes the vocal cord over. Unfortunately, it doesn't help with, again, dyspnea on exertion. Lastly, again, I showed you this picture once already, but you can do nerve grafting. So if you know the event that happened, whether it was thyroid surgery or whether it doesn't recover from an intubation over time, you can go in and you can actually do a nerve graft or to fix the nerve in this area, very similar to the photo that I showed you before. Again, another option for someone who would have a nerve injury. So what is nerve grafting? We have a couple more slides and I'll show you a case and then we should have some time for questions. So nerve grafting is taking a nerve from one part of the body to the other. I know Dr. Rivera discussed this, as well, but this is a really important concept. So you can actually take something called an autograft. So we make an incision on your leg or your arm, and we could take one nerve out and we could put it somewhere else. That works for some small sensory nerves, but there's always a deficit. So if we choose to take a nerve from your leg, we'll always have some numbness on your leg at the sacrifice of having to put it up here on your, for your jaw or on your tongue or for your recurrent laryngeal nerve. You can get lots of lengths from these nerves, right? There's a lot of different lengths. And then, maybe you could see one of these nerves while you're working. So if you have someone that has a thyroid cancer, for example, there might be a sensory nerve in the neck that you could borrow while you're using it. There's also something called an allograft. So an allograft is actually a cadaveric nerve that's been specially cleaned and it's been prepared so that you can use that nerve in your body. You don't reject it like a transplant, but that nerve is completely cleaned of all the cells, but you can use it as like a conduit. And so those nerves don't require extra incisions. So we can take those nerves right off the shelf and use them. There is some cost associated with them, but the insurance typically covers that. And the distance is limited to about 7 centimeters. And, this really doesn't matter for most things. I know Dr. Rivera needs some time. She needs a longer nerve than that. But usually for a lingual nerve or an inferior alveolar nerve or a recurrent laryngeal nerve, you only need 3 to 5 centimeters of a nerve to repair this. Another important thing besides, what a nerve graft is the timing. And so, we try to do these nerves sooner rather than later if we know the mechanism of injury or we know that they're cut. So if we're not sure what happened, we do the serial monitoring. But if we know that that nerve's been kind of cut or damaged with an implant right away, we can see the implant in the canal, or we know that the recurrent laryngeal nerve was cut from a thyroid surgery. We try to go in there pretty soon to find the edges, put things together, and go do it. And again, if you do it early, the data is pretty clear and it's also pretty obvious. There's less of a time to have neurosensory disturbances. And so patients reported like an earlier intervention has a better outcome. I'll show you one case example. These will be maybe the photos of patient photos that if you're squeamish, you may want to turn away from a few of these. I have some surgical pictures. Something I learned early in my practice was that tongue numbness after cancer surgery was really bothersome. And so there's this concept of lingual nerve coaptation. So, let's say you have a cancer of the tongue and you have to remove that. You're removing some of the tongue skin, and muscle and nerves. But what if you were able to replace that nerve with a new nerve and some new sensory tissue? And so this was a paper that, I published looking at what it's like to live with a kind of a numb tongue and what happens when you graft nerves to it. So this is a gentleman who had a tongue cancer. I'll show you some more of his pictures on this, but this is a new piece of skin we put on the tongue to rebuild it. So this is actually from his radial forearm. So we take skin and fat from the arm, we bring a nerve with it, we hook up a new artery and a vein, so it's like a living, breathing transplant, and then we actually hook up the nerve. And the question I had, and my co-authors on this paper had, is, what does nerve grafting do to tongue function? So again, I showed you a different picture of this. The lingual nerve comes down, it goes into many branches into the tongue. But for this procedure, we have to cut some of these branches. And so the whole premise of this study was, what happens when you cut the branches and then hook them back up to a new piece of skin in that area. Here's our cohort of patients. We had 84 patients in the whole group, and we did what's called neurotized flaps in 41 and non-neurotized in 43. So again, the 41 patients had new nerves hooked up into their tongue, and the other 43 did not. And we wanted to compare these two groups to see what their swallowing and their speech was like. And so here's what it showed. And so the blue bars are the scores patients gave for their functional outcome or their reconstruction. And then the red bars are the non-neurotized or the non-nerve reconstructions. So here you can see nutritional mode. So the blue bars, they all ate an oral diet. And you can see some of the red bars, they had tube feeds, and one patient was even G-tube dependent. Same thing with range of liquids. So again, range of liquids was very good. This means that you can have really any type of liquid consistency without issue. And you can see there was some limitations in patients in their liquid consumption. The solids was even more stark. So again, you could see that almost all range of solids, so every type of solid food you could think of, did really well with the neurotized flaps, whereas the non-neurotized flaps had patients who couldn't swallow as well. And so this led me and my group at the University of Pittsburgh to really do a lot of heavy nerve grafting on tongue reconstruction to improve sensation, which translates to an improved functional outcome. So what does this look like? Again, gross pictures. This is an example of a tongue cancer on the side of the tongue here. Usually they're white or raised, and they can have little, reddish areas as well. What you do for this is you have to measure a centimeter around the tongue. These can grow with little fingers. And so this is what it looks like when it's out. So you have to remove this part of the tongue. When this happens, you can imagine you have to reconstruct this with something because it would really tether the tongue if you sewed everything up and let it scar. For this, we use a radial forearm free flap. And so you can take the skin and fat from the arm, and then you can take the artery and vein with it. So this is an example of the skin of the arm. This is some of the fat of the arm, and this is the new artery and vein. And think of this like a transplant. We've heard of kidney transplants or liver transplants. This is actually your own body's transplant from one place to another. So there's almost no rejection of these, and they heal really well. This is what it looks like when you're done. You're really swollen, and you get a lot of tongue swelling. And this is that picture I showed you. So this is about 2 months. And so you can see that the skin's really healthy, and he'll have new sensation to that area when the nerves kind of fully grow back from putting in the nerve grafting or coaptation. I'll show you some other quick examples. So this is just called a lateral arm. So some patients don't want tissue from their arm or hand taken, so we could take it up higher on the side of the arm. And then to try to even avoid arms, a lot of people have tattoos on their arms. We can actually take pieces from the leg. And so we actually wrote a study to look at pieces of skin from the leg to rebuild the tongue with. And again, here's an example of that. So we take skin from here and then rebuild the tongue. Again, that completes the lingual nerve, inferior alveolar nerve, and recurrent laryngeal nerve talk. If you have any questions, I'd be happy to answer them. And thank you for coming on the webinar tonight.
Dr. Spector, that was fantastic. Thank you for sharing your expertise with us tonight. I did have several questions of my own after listening to your talk, but I wanted to make sure we address any questions that come up in the chat box and prioritize those. So we have one currently, so I'll just jump straight to that one. And it is applicable to the case study you presented on neurotization of radial forearm free flaps for tongue reconstruction, but a little bit different. The question is regarding your experience using nerve to muscle neurotization for recurrent laryngeal nerve injury specifically. So do you have any thoughts on that experience? How common is that as opposed to just kind of grafting a recurrent laryngeal nerve injury? Is there good evidence for neurotization of the musculature of the larynx after this kind of injury?
That is a great question. Thank you for asking that question. What the question is describing is that when we hook up the recurrent laryngeal nerve, it actually provides a single nerve actually provides to maybe 5 or 6 muscles. And so that single nerve will go and provide all these different muscles of the voice box that do different things. There's a concept of just a nerve muscle reinnervation where you can sew a single nerve into a single muscle to control it better. This is really important for patients who have dual nerve injuries. So what'll happen is that when you have both of your recurrent laryngeal nerves injured, you can actually not be able to breathe at all because both vocal cords won't move, and then you can need a trach, so a hole in the neck to breathe out of. There's this concept of nerve muscle reinnervation where you can actually sew a single nerve into a single muscle. So there's only one muscle of the voice box that opens the voice box. It's called the posterior cricoarytenoid muscle. So if you sew just into that nerve or that nerve into that muscle, you might get more opening of the voice box to remove a trach. I've only performed that operation one time. It was successful, but it was successful for removing the trach, but swallowing was still hard for that patient. And so the short answer is yes, I have very limited experience. Yes, it's a cool area that we're trying to move into with vocal reinnervation, and it's a great question.
Thank you. I know that's kind of a tough situation. I remember speaking to another kind of expert in recurrent laryngeal nerve injury, and they alluded to the push and pull issue. If the patient wants to breathe, then any intervention that they may be interested in may make it harder for them to speak and swallow, and vice versa. So it's really hard to accomplish all these goals simultaneously in patients with this injury. I had another question here asking about your preference for autograft donor. How do you choose which nerve to use as a donor nerve for these various types of injuries?
Another great question. So it really depends on what your nerve caliber is and how long you need. So short segments are very easy to find of almost any nerve. So the greater auricular nerve behind the ear can give you a pretty good size nerve that can match maybe a lingual nerve or an inferior alveolar nerve for an autograft. Long segments almost always have to come from the leg or the sural nerve. Kind of medium segments can come from the front of the arm, so you can get a little numbness on your forearm, but that's another good place for nerves to go. So it's really a discussion between me and my patient to say, okay, here's the deficit that we're going to have up here, and what are we willing to use as an autograft, and where do you want a little numbness somewhere else in the body? Because almost certainly there's going to be some numbness from the graft harvest.
Yeah, maybe if someone's a marathon runner, they might not be as excited, for you to take a nerve from their leg, for example. So I know patient preference definitely comes into play. This is another good question for you specifically. I think I know the answer based on talking to some of your residents. Do you do your nerve repairs typically under the microscope?
So for most nerve repairs, I do under loop magnification. So always under magnification. The most common nerve repairs I'm really doing are inferior alveolar nerves. So if you look at those 3 different nerves, inferior alveolar nerve is the most common from mandibular surgery. And so that's a 3 to 4 millimeter nerve, and it does really well with loop magnification. If I'm dealing with smaller nerves or more difficult anastomoses, then we use a microscope, but always under at least 2.5 magnification with loops.
we had another question that popped up. I think we still have time. Um, how do you kind of reconcile your nerve repair work with any cases that you do with robotic assisted surgery? Is the robotic surgical technology applicable at this time to nerve repairs, or are you still kind of considering them kind of distinct, and there's not quite so much overlap?
Yeah, another great question. The most common time we use robotic surgery is for cancers of the tonsil and tongue base. And so you can see the lingual nerve when you're doing a robotic surgery. The instruments on the robot are not made to hold microsuture. And so when you're using them, there's a couple of different retractors that you can use or graspers as well as kind of cutting tools. They're too big for nerve repair. And so anytime when doing robotic surgery, if we have to repair a nerve, we do that under loop magnification after we bring the robot out. But another great question.
I think we have time for one more question, I guess, which will be my question, which kind of gets to the whole heart of the Global Nerve Foundation's mission. So if any of our listeners or audience members have experienced any of the issues that you described in your talk today, or know someone who has, or is interested in referring a patient with these issues, how do you recommend they go about identifying someone in their area or someone accessible to them who may be able to help them with these conditions? Is it enough to just ask for kind of an ENT specialist, a dental specialist? What general advice do you have? Because these aren't things that come up, quite as routinely as other conditions.
That's a hard question, Dr. Rivera.
Sorry, I say my
No,
mine was hardest.
this is a great one. So the Global Nerve Foundation does have resources for this. You can find a provider near you. Even looking up kind of nerve techniques or nerve graft providers, you may find them online. There really are 3 specialists that will do this. So Christina and I are otolaryngologists who kind of have overlap in this area. Oral maxillofacial surgeons also work on some of these same nerves on the lip and of the lingual nerve and jaw. Plastic surgeons sometimes deal with head and neck nerves. And so really in your area, I mean, you need asking around or talking to your primary care, or even just looking on kind of a website like the Global Nerve Foundation website. Or I know Axogen, who provides some of these allografts, their website has a list of kind of preferred providers that at least can get you in the right direction of where you're going.
Okay. Thank you. That was fantastic.
Excellent. Well, thank you both again for being here tonight. I really appreciate it. Outstanding webinar, Dr. Spector. And thank you to Dr. Iver for coming back to moderate as well. We will send out links. Give us a couple days to get it up on YouTube. We'll send out links for those of you who need to go back and rewatch with so much great information. And again, we'll follow up probably Monday. So keep an eye out. If you have any questions, please feel free to respond to those emails. We're happy to provide additional resources or answer any other questions that people might have had. But thank you both to our speaker and moderator again tonight. We really appreciate the time, and I hope everybody has a great rest of the night.
There's one more question, actually. I just saw it pop up. If we have time.
Thank you. Thank you for
Yeah.
catching that.
So this question has to do with sensory deficit after dental procedures. They are usually accidental. And so again, you go in for routine wisdom tooth or filling or a root canal, and there's just things happen. Sometimes the needle randomly can go into the nerve, right? And you don't want it in the nerve, you kind of want it around the nerve for numbing. But if it goes in there and causes a break in the nerve or a neuroma, it can happen. So the majority of these are accidental, and clearly they're very low. But think about how common dental work is, right? We might all get a number of procedures over our lifetime times the whole population. And so they're more common than you think. So again, always happy to you should ask questions, and you should get some information on this if it happens to you.
So, sorry, I'm getting ready for dental work myself. So as a question, do patients or do surgeons, when you're going for those procedures, is it normal to do nerve imaging ahead of time as far as being able to really visualize where everything is? Do they show up on common X-rays? Like what is kind of what should people be looking for prior to kind of having work done?
Yeah, if you're getting lower mandibular work done, you'll always have an X-ray ahead of time, right? For those. Actually, you'll always have X-rays ahead of time, but that can show you where the inferior alveolar nerve is on each side. The lingual nerve damage is more of a kind of a random injection damage or a damage that way. And so, but yeah, there's always images that can be taken to really show you where those are, but it can still happen.
Okay, excellent. Well, again, thank you both. Really appreciate it. Thank you for everyone for being here tonight, and we will be sure to send out follow information soon. Thank you. Have a great night.
Thanks.